All right. Well, good morning and welcome everybody. I'm excited for today's topic. This has always been a passion of mine. For those of you who don't know me, I'm Dr. Joel Phillips, medical director over at Trinity, but clinically, I'm a neurologist by training and then went through the palliative care fellowship here. So my approach to palliative care really is more of that neuropalliative approach. So I see a lot of patients with chronic neurologic illnesses. And as you guys go through the fellowship, you guys are going to see a lot of principles and concepts of neurology as they come up throughout the year. So we've given this lecture a few times and fellows have found it helpful along the way. So for those of you who have heard it before, I have tried to add a few new pearls to it. So it'll be the same but different, but hopefully everybody can take something away from this lecture. So we'll go ahead and get started. All right, so disclosures. Got no disclosures. What we're going to do today is really broadly understand the role of neuropalliative care. We'll go through the historical context, briefly touch on inpatient, but over the last couple of years, focus has really been more on outpatient. We'll talk about some treatment strategies, management, symptom management, talk about advanced care planning, but I do really want to make sure that we have time to focus on caregivers as well because of this patient population. That caregiver burden tends to be pretty high. So let's start with some history. I think I'm able to advance now, John, so I'm going to move this down. So
yeah, put it right wherever you want. Once you click that, it usually
it'd be nice if we could minimize it, but we'll work with that. So going back into some of the history, looking back at some of the documentations and where the American Academy of Neurology has been back as early as 1996, there was a provision for neurologists to function as primary care specialists for their patients, not even palliative, but neurologists tend to come in to see neurology patients come in to see the neurologist more often than their PCPs. So there was a push for that to take place. But then there wasn't anything recent until just kind of some things periodically over the next 2 decades. They came up with some statements about what to do for persistent vegetative state, irreversibly paralyzed patients who retain cognition, and those lacking decisional capacity. The AAN around 2016-17, it used to have a pain and palliative care section that split into a pain section and a palliative care section. In 2018, American Academy of Hospice and Palliative Medicine developed a special interest group focused on neuropalliative care. But the big date to remember is 2020. That's when the International Neuropalliative Care Society came into formation and started functioning as a nonprofit. So since then, there's been a lot of work in providing resources to clinicians, to fellows, residents, but also patients and families as well.
Do you want to give your pitch?
Oh, that's at the end.
Okay.
So in 2022, AAN came out with a position statement on guidance to neuropalliative care. If you guys want a good read, it's maybe 5 to 6 pages long. So it's not a terrible read or terribly long, but is a good summary. So definitely one to kind of put in your repertoire. How do we define neuropalliative care? Claire Kreutzfeldt is one of the founding physicians. She's an intensivist out in Washington, and she defines it this way. A neuropalliative care approach is a palliative care that focuses on specific needs of patients with neurologic illness and their families. Neuropalliative care thus represents both an emerging subspecialty with neurology and palliative care, as well as a holistic approach to people suffering from neurologic illnesses. So it really is a blending of 2 worlds. There are things that palliative care carries over into neurology, but neurology also carries back into palliative care. This is how I define it to my patients. So if you're working in the clinic with me, this is my elevator speech of sorts. So patients know, number one, why they're here to see me, because that's usually their first question is, why do I have another doctor to see? Like Dr. X, I'm a neurologist, where he or she had her specialty training in either movement or neuro-oncology. My training was in palliative care. What that means is I approach your condition from a different perspective. My role is to come alongside you and your family, looking at how your condition affects your day-to-day life, to relive symptoms, look down the road at treatments you may or may not want to consider, and provide that support along the way. We often talk about a focus on living well, but also about looking at decisions before we have to make panicked in the moment sort of decisions like emergent trach or something along those lines. So who's going to benefit from neuropalliative care? This slide was updated just to give the entire list of who may qualify. So we got about 8 different categories. We'll go into some of these more in detail, but this is just more to show you that comprehensive sort of list of chronic neurologic illnesses where palliative care approach may be appropriate to utilize. So the timing of palliative care, when should we be doing this? We really can start seeing people at any time. Early on, it might be more of emotional support, talk about what the diagnosis means, but not really go much into advanced care planning or things like that. They may not even have many symptoms, but really be there to talk more about developing that roadmap. During the middle stages, it might be more of talking about symptoms. I say non-motor here because this is specific to Parkinson's in this case. But goals of care, we might start talking a little bit more about them. And then in those late stages, more of the transitions to hospice. Across the board, nobody's quite defined when to start. The mantra's always been earlier the better. For neurologic patients, oftentimes patients may lose that decision-making capacity. So it's good to get your foot in the door early, start some of those goals of care conversations, especially if you think that there's going to be that cognitive component. If they may develop a dementia or something along the way, you may at least be talking about advanced directives or naming a power of attorney early on. So let's briefly talk about some inpatient palliative care. The needs you'll see on the inpatient side, typically these are patients with something acute neurologic going on. Stroke, either ischemic or hemorrhagic, traumatic brain injury, status epilepticus, inflammatory. We've had patients with the NMDA encephalopathy being hospitalized for months, and we were able to come alongside and support them through that whole process. Progression of disease. So you'll get patients with ALS who are in respiratory failure, or you'll get a Parkinson's patient with dysphagia or aspiration pneumonia, patients with dementias or multiple sclerosis. Often we're talking goals of care. That's probably more of the emphasis on the inpatient side, looking at those treatment options, talking about end-of-life decisions. But there is some symptom management that comes along the way, but probably to a less degree. You guys have seen these trajectories before, so I really have this slide in here just to put into perspective how that may look from a neurologic standpoint. But I really wanted to highlight a different trajectory that Dr. Holloway out of Rochester actually named several years ago, and he's calling this the 4th trajectory. It really describes that prognostic uncertainty that we see in acute neurologic situations. In that inpatient setting, you're seeing patients who are high functioning and then suddenly something happens. That stroke happens, that function drops very quickly within minutes to hours. And then you get to this kind of fork in the road at some point where the body's just not going to be able to continue maintaining homeostasis, and you may be leading more towards that death, or you may have that possibility of recovery to a lower functional status, but survival may be months or years beyond that. So there's a lot of unknown that goes into these acute neurologic sort of diseases. And a lot of what we have to do from that palliative perspective is talk through that uncertainty and really ask patients' families, what would the patient be willing to endure, and what would good outcomes be like for this patient? What would they be describing as that acceptable quality of life? And that may help us determine where goals of care go. Within neurology, on the inpatient side and the outpatient side, there really is a very large overlap between neurology, palliative care, and even rehab medicine. So when you're looking at the strokes, again, I'll use that as an example here. That acute setting, you really need your neurologist. You need to have the neuro workup, the imaging, the neuro exams while the patient stabilizes. But as they get closer to discharge, you may have neurologic deficits, but a good survival, which leads to that long-term support. We really rely on our rehab colleagues to take over a lot of that day-to-day care and that long-term treatment for a patient. But as patients age, as illness progresses, there's suddenly a role for more of this neuropalliative rehab, where there's that overlap between palliative care and rehab medicine, which may evolve and morph back into more of a palliative care approach. Now, what I like about this slide is anything you see blue is really where palliative care is very heavy as well. So palliative care on the early end with diagnosis is very important, but may come into play more towards the end of life and more of the advanced stages. Palliative care probably takes a leading role, and you can see neurology really kind of drops out of the picture as well. So this is a fluid and dynamic sort of thing, but very good to have that partnership with our rehab people. So I did throw in this slide. Kara may appreciate this one as well, but that palliative rehab, really the definition is it's function-directed care delivered in partnership with the other disciplines. It's aligned with the values of the patients who have serious but also incurable illnesses. So we often think of rehab as something for people who are going to get better or get over something, but people with incurable illnesses have a need for rehab as well. Purpose really is to provide that rehab care in a potentially time-limited sort of a setting. And the ALS clinic is a great example of this, where we have PT and OT and speech right in the clinic, helping patients meet their goals and adapt to a progressive neurologic illness over time. In the ICU, and I apologize to the people in the room, you can't see my headers very well, but this is talking about what do we deal with in the neuro ICU. Oftentimes we're talking about that loss of personhood. Function and independence is suddenly lost. Cognition and personality may be lost either temporarily or more permanently. We're often talking about who are those surrogate decision makers. A lot of what we do as we try to figure out that treatment trajectory is go down that path of shared decision making, trying to figure out what the physiologic realities are and what patient goals and values are, trying to figure out how we can meet in the middle with those. And often we'll be dealing with brain death, talking with patients and family, well, not the patients, but with families through the process of brain death and what that may look like. And it may be important to have palliative care as that supportive service as the ICU is going about their process of the brain death protocol. All right, so in the intensive care unit again, I wanted to highlight a partnership we had a couple of years ago when we had one of our neurointensivists come on board. It was about the time that I came on board as palliative care as well. So we were able to do a retrospective study. We looked at 2 years of intensive care and palliative care involvement for neurologic patients before our arrival, and then 2 years after. And what we were looking at is number of palliative care consults, hospital length of stay, ICU length of stay, and mortality. And I want to highlight for you in this, I'll move this in a second. This is just kind of some of the data of the study itself. But I wanted to highlight there's no significant difference or increase in palliative care consults. There is a lower hospital median length of stay, so it went from 11 to 8 days. ICU length of stay was shorter, but the mortality rate did not change. And I want to highlight that. Oftentimes palliative care is associated with death and dying, but the rate was the same, 39% for both populations. So what this highlighted to me was that palliative care involvement really allowed for that lower median length of stay without that change in mortality. My interpretation of that is we're getting the patients to where they want to be sooner. We're helping them meet their goals sooner. And that's a lot of the purpose that we can serve in that inpatient setting. Let's talk about outpatient palliative care, where a lot of the movement has gone over the last several years. Early clinics started. I want to get rid of that too. Okay. Early clinics started really more on a disease focus, either like in a palliative Parkinson's clinic or in an ALS clinic. Often they had either a movement specialist or a palliative physician, a nurse, spiritual care, some sort of care coordinator, and then variable services included nurses, social workers, PT, OT, and psychology. A lot of the early findings really emphasized the amount of unrecognized symptoms that went unaddressed in regular neurology clinics, particularly with Parkinson's. There's a comparison that Parkinson's patients probably have as much symptom burden as a patient with advanced cancer. And it's something that we just have to ask about to understand what those symptoms really are. So a lot of the common ones are constipation, dysphagia, anxiety, pain, and drowsiness. I've put in here the Edmonton Symptom Assessment Scale just as an example of something that I'm assessing in my patients on a routine basis. There's actually an ESAS PD for Parkinson's as well, if you guys are interested in focusing on symptoms in that specific illness. That palliative care and neuro partnership, as we look at what that really needs to be, somebody has got their speakers on again.
Yeah, I'm gonna turn it off.
All right. So the suggested role of
Don't have a speaker on here. My speaker.
good. How's this? There we go. Okay. So really, when we look at what the referral needs to be, it really should be based on needs rather than prognosis. So oftentimes a neurologist may be referring, saying, you know, this patient is in advanced Parkinson's. We're talking about transitions in care. We might need to bring in hospice at this point. Really, we'd rather be working much further upstream. There's a lot of different approaches. We can focus on specific needs and symptoms. So patient early on might have more sialorrhea or might have more constipation or stiffness that is just out of the scope of what a neurologist is used to doing. We can come in just for kind of one-time assessments, or often we can do more of a co-management where they come to see the palliative neurologist, but also their regular neurologist who may be managing more of the Parkinson's or the neuromuscular disorder, and you're just kind of alternating visits. And then the final approach is really assuming that ongoing care. And that's when we've really said, the neurologist has really said, you know, we've exhausted kind of what I'm doing from that neurologic standpoint. The Cinemet's not working. The other movement medications just are not going to have effect at this point. Why don't you just kind of take over from that palliative care perspective? So oftentimes patients can actually kind of move through that continuum as well, which in our clinic seems to be fairly seamless for a lot of those patients. So who benefits from coming to the outpatient clinic? The few different categories. First of all is patients with chronic progressive neurologic illnesses, such as Parkinson's or other movement disorders, patients with ALS, muscular dystrophies, dementias, epilepsy, and then neuroinflammatory. So MS and some of the leukodystrophies. Surprisingly, I'm seeing a lot less MS than I thought I would see in this role, but there's been so many changes in the disease-modifying therapies for MS that is something that's much more manageable with much less symptom burden than it used to have. So a lot of those patients have not been making it to the palliative clinic like I thought they may be, but we stay plenty busy with the patients that we do have. I also wanted to highlight patients with chronic stable conditions. So a lot of these patients with stroke, TBI, spinal cord injuries may end up in the rehab clinics and may be appropriately there for a long time. But I've got a handful of patients who have these symptoms and are seeing me as the neurologist, but also helping with complex symptoms at the same time. Central pain is a great example where patients may have had a thalamic stroke or something along those lines, where there's just very difficult to manage hyperalgesia or allodynia that we can get some of our palliative meds going to help out. And then there's also the neuro-oncologic approach. I highlight this one separately because it really is a different approach than that of a chronic progressive neurologic illness, which may take more of a course over decades, decades or years. With glioblastoma, anaplastic astrocytomas, there's more of an acute symptom burden. Patients need to be seen more frequently as things are changing, developing, as radiation is starting and ending, and chemotherapy is starting and ending. A lot more times for intervention where palliative would be appropriate. But specifically to this patient population, we see a lot of seizures. Headaches are another big one. Fatigue and cognitive changes. We see a lot of patients with essentially frontal lobe injuries from their tumor and resection, and we're dealing with support, coping, loss of personality, loss of personhood, a change in who somebody was prior to where their tumor was. So early on, again, ambulatory clinics were embedded or consultative. We are seeing some, especially on the international stage, where we're seeing some home-based care. A lot of neuropalliative care in Europe is actually carried out through the geriatrics population. So they've just traditionally been the patients who are caring for patients who are treating patients with Parkinson's or some of these other neurologic illnesses of older age. So they'll do a lot of this home-based care or in facilities. More and more, we're seeing telemedicine as a way to reach patients as well. As mobility becomes more difficult, they may not be able to come into the clinic quite as easily. It might be a 3-hour process just to get to the clinic. So telemedicine visits have been very helpful for a lot of patients. So when we look at a multidisciplinary clinic, this is an example of staff and services from our clinic that we supply. We have physicians, so a neuromuscular physician, a neuropalliative care physician. Some will have pulmonologists involved in those clinics. Again, we'll have a dedicated nurse who kind of carries out the in-between clinic phone calls, prior authorizations, prescriptions, patient questions, coordinating care. We have a respiratory therapist who does PFTs for us every week. We have a representative from the ALS Association, making sure that patients have support from those community organizations in the area. We have a dietitian, PT, OT. We have a wheelchair representative for mobility devices, speech therapist, both for swallow evaluations and for communication. But then we also have a social worker who helps with a lot of the community resources as well. So it's a large team that all gets to see the patients. They kind of rotate in and out on an as-needed basis. But then we finish with an interdisciplinary meeting at the end of the day where we cover the cases of the day, talk about the patients, and really highlight their needs and how we're all going to approach that as a team. So a few benefits that I came across in research for this year, and John, this is one of the new slides. So
right.
we got some statistics here. So we see patients in an ALS clinic have fewer hospital admissions, but when they are admitted, they're shorter admissions. So we're cutting that almost in half from 12 days down to 6 days. Patients report a better quality of life, and they're also more likely to receive PEG and talk about non-invasive ventilation. So those are things we'll talk about as the lecture goes on, but just in kind of an interesting idea that's coming up more in these interdisciplinary clinics than anywhere else. Patients coming to neuropalliative care with dementia, there's less interventions at the end of life for these patients. I've noticed a drop in amount of PEG tube or dysphagia consults on our inpatient team with the advent of neuropalliative care on our service or in the system, because we're having that PEG tube conversation months or years before it needs to take place and becomes a non-issue when patients come in with aspiration pneumonia. There's fewer unmet needs in the last week of life, greater family satisfaction at the end of life. and they're less likely to die in hospital. Again, it's because we've got the chance to talk about a lot of this outpatient and develop that plan of care before they get hospitalized. So let's talk about some treatment strategies and management. I want to try to cover more of the common neurologic symptoms you guys may run into. And the list is big. So just from that broad category, a lot of what we deal with is movement, speech, cognition, swallow, breathing as the muscles of respiration can be affected. We're dealing a lot with dyspnea, which may lead to daytime fatigue. Seizures is another big thing we're dealing with. There's a loss of independence, loss of cognition, anxiety over that next seizure. So these are all things that we're dealing with more or less on each patient. This is just kind of the broad category. So I'm going to throw this out to everybody here in the room, but also out on the web. When we're looking at enteral feeding or a peg tube, is this something that's life prolonging? For Parkinson's and dementia, what are your guys' thoughts?
Say yes.
Yes, life prolonging? Okay. No.
Yes.
So it actually, number one, it doesn't reduce that risk of aspiration. So it's a quick, easy, convenient way to get food and nutrition in, but patients can still aspirate on their secretions and still have aspiration pneumonia. But number two, gut motility may be affected. By the time we're talking about peg tube for these patients, the body's already starting to shut down. Parkinson's is a movement disorder. The gut has muscles to it, so that coordination of the gut motility is lost. So you may put food in and it's just going to sit there. So it may cause more of that nausea, distension, and the body may not even be able to process the calories. So now as we talk about stroke and neuromuscular disease, is this life prolonging? And I have Kara saying yes, it is. So in stroke, peg tube might actually be a great bridge therapy. If somebody has acute dysphagia at the time of stroke, that may be something that will recover over the next weeks or months. So having a means of artificial nutrition for that time can be very helpful to get them to the next spot to find what that new functional baseline is. And gut motility typically in these cases is not affected to the same degree as in Parkinson's and dementia. So looking more closely at peg tube, we'll often use that artificial nutrition when that dysphagia arises, but patients, sorry, this is a, so it's a lot of what the same thing that we talked about on that last slide, how with stroke movement disorders, that's really intended to maintain, specifically to ALS, enteral feeding is really more to kind of maintain and stabilize as well. It's not intended to reverse that cachexia. So any amount of nutrition that we put in, we're still going to see that weight loss over time with ALS. Where we do see that benefit is we can stabilize that BMI. Again, no reduction to that aspiration, but quality of life is still a big question mark. A lot of times, when you look at the literature, patients will say, yes, this is great. It makes it easy for me to get my calories in. I just hook up my feeding. I don't have to worry about it taking hours to chew and swallow my food. You ask caregivers, and there's a lot of work that goes into it, setting up, preparing the supplements, preparing the feeds, flushing the tube, keeping the area around it, the skin clean and dry. So there's still a debate about whether or not it truly does improve quality of life, and it depends on who you ask. So with that, a few statistics on Parkinson's disease. Patients who do get peg tube placed, the 30-day mortality is still 6%. So that's not benign. The rate of aspiration pneumonia is still 22%. So again, it doesn't reduce that risk. Looking at ALS patients with PEG tube and those who are also on non-invasive ventilation, so the combination of the two, survival rate is actually measured at about 330 days. So that can significantly extend that lifespan for people. So that's something good to bring up when you're talking to patients about the role of a PEG tube in this sort of situation. Other good anticipatory guidance when you're introducing the PEG, also had that conversation about discontinuation. It's good to have that exit strategy. Let patients know that even though this is something that we're starting, if we come to a point where we're not finding benefit in it anymore, we can go ahead and stop it. We don't have to keep doing it if we're not finding that benefit. But then it's also important, have speech therapy involved, have the dietitian involved. They can really help with the conversations, help talk about feeding and what things may look like. Sialorrhea is another big one for patients. A lot of it is not overproduction of saliva, but more of a development of dysphagia and coordinating swallow, so that the secretions kind of pool in the mouth. So from a pharmacologic standpoint, tricyclics are still the textbook answer for how to control that sialorrhea. In reality, atropine eye drops, ophthalmic solution used sublingual is a great PRN way of doing it. If we need something more regular, I'm a big fan of glycopyrrolate because it does not cross the blood-brain barrier. So you're not getting the anticholinergic effects that you would see if you used other medications. Then if those things fail or you're still having trouble, Botox to the parotid and to the submandibular glands is a great way to get long-term effect. We usually start with a lower dose, see how patients do with it, and titrate doses over the course of a year or so. Patients can get the injections about every 3 months. And what you get is what you get for those 3 months. So if you overshoot and it's a larger dose, they're going to be dealing with dry mouth for those 3 months. So thickened secretions are another issue, separate from sialorrhea. Often we're looking at mucolytics like guaifenesin. That's a great one to use to really break those secretions up. I'm a huge fan of nebulized 3% saline, especially if already got a non-invasive ventilator. You can also get a nebulizer separate for them. It's a good way of just inhaling a couple times a day. That solution really does a good job of making those secretions easier to cough up. Acetylcysteine is another one that you can use if that 3% doesn't work. Suction or cough assist. Often we're talking about an afflo vest as well, something that you put on and it provides percussion to the chest to break those secretions up. And then increased fluids, make sure patients are staying hydrated. That's another good non-pharmacologic way. And this is just for Botox. If you guys ever are in my clinic, this is where you'll see we inject in the parotid and submandibular glands. We'll get into a lot of detail on breathing when we do the non-invasive lecture, so I'm just going to cover this briefly. It's more of a mechanics of breathing that's affected. So we're focusing when we look at PFTs more on the maximum inspiratory pressure, maximum expiratory pressure, and that forced vital capacity. A lot of those things come into play as we're looking at procedures for placing PEG tube and things of that sort. Good takeaway today, we don't need supplemental oxygen for our ALS patients or patients with neuromuscular disease. It's not a gas exchange problem, it's an airflow problem. So if we can get that airflow in, usually room air is good enough to get that respiration. Opiates are another good thing that you can use for dyspnea along the way. So with pain, this is specifically about the non-neuropathic pain, so more of the somatic pain. We can see a lot of muscle cramping from increased tone or spasticity. Joint pain, as we see much muscle atrophy, we may see that joints aren't seating as nicely. We see a lot of frozen shoulder in ALS. So a lot of good reasons for musculoskeletal pain. Immobility as well, prolonged positioning. You can start with Tylenol, NSAIDs. Muscle relaxants may be good. I use muscle relaxants with some caution because you may be relaxing muscles too much, getting rid of some of that tone that patients depend on for transitions, transfers from chair to bed to toilet, or even ambulation. So low dose muscle relaxants may be good. Botox may have a role as well for more muscle spasticity because of the local effect. Um, but also look at supportive equipment. Power wheelchairs have tilt and recline features. You can get pressure relieving cushions as well as mattress overlays. A hospital bed can help with repositioning overnight as well. Pseudobulbar affect. We see this in ALS, in some Parkinson's or movement type issues. It's really a neurodegeneration of the corticopontocerebellar pathways in which we see an exaggerated motor response to an emotional stimulus. So you may read a Hallmark greeting card and, you know, it might be a tearjerker, but patients will just start crying uncontrollably after reading that card, or somebody will tell a stupid dad joke and it's just uncontrollable laughter afterwards. It's almost that laughter or crying out of proportion for what you would see. Historically, we've used SSRIs or antidepressants, but first line therapy now really is Nuedexta, which is a combination dextromethorphan quinidine. It's commercially available in capsules, still pretty expensive. For patients who can't swallow capsules, we have been known to compound that, which greatly reduces the cost, but also allows you to use the PEG tube to administer it in a liquid form. So the dextromethorphan is really the active ingredient, working as that NMDA receptor antagonist. Quinidine is really there just to inhibit the liver enzymes so that the dextromethorphan can last longer. So if you're really in a lot of trouble, you could always just write a prescription for short-acting dextromethorphan frequently throughout the day. That would be a solution, but probably not the ideal one if we can get something that's a little more long-acting for them. So when we look at, I want to look at my heading here, impaired cognition. A lot of patients will have impaired cognition along the way. In ALS, there are some studies measuring 5 to 15% of patients will have FTD. There's been other studies showing up to 30% of patients may have that FTD. So look for that disinhibition, lack of empathy, apathy, poor executive function. You may be dealing with a cognitive issue on top of their neurologic condition. Some may present with that primary progressive aphasia, which is more difficult to detect in your ALS patients. And this really adds to that caregiver burden. So it's good to be aware of. So let's talk about advanced care planning. A lot of times what we need to do early on is talk about those future treatment options. What does a PEG look like for you? How are we going to use it for dysphagia? Is that something that fits into your idea of a plan of care? Non-invasive ventilation. What does it look like and what does it mean for you? Would it lead to tracheostomy? Talking about living arrangements. Maybe we're good living at home right now, but over time, as more care is needed, maybe we need to talk about transitions to a nursing facility, hospice at some point down the road. And then advanced directives. It's good to bring up that power of attorney early and start exploring what code status may look like. I'll usually do my introductory visits, at least asking where these things stand. We may not go deep that first time, but just starting to normalize that as part of the process of things we're going to talk about. When we look at advanced care planning at the different stages early on, patients are really looking for that prognosis or that education about the disease, what to expect down the road. So you may talk about treatments that help them along the way, but it's really just kind of, they're still in that information gathering stage and really want support in trying to find the right resources and information. But you can also use that time to start planning for death as a natural outcome. Patients know these are terminal illnesses, and we can focus on, yes, death is part of this. We can focus on living well, but part of living well is starting to talk about what that time may look like at the end. Prognostication is difficult, particularly towards that end stage, but it's something good to, patients are always looking for what does that trend look like. I'll often talk about patterns for patients. I'll tell patients, I don't know what it's going to look like to you for specifically, but I expect that you're going to be dealing with dysphagia or stiffness or constipation. That's typically par for the course. We'll see when that happens for you, but those are things you can expect. Patients tend to appreciate at least those broad statements as well. One patient put it very well, or her spouse did, being able to talk about the most difficult decisions and have those conversations before it's an urgent or immediate need has been hugely important to me. It's made it so the hard is not just hanging over our heads, but out in the open, and we can move on to focus on more positive things. So it's the elephant in the room. Let's talk about that and put it aside. We may come back to talk about it later on again, but let's address it so we're not tiptoeing around it. So this is a survey we did in the clinic a couple years ago, looking at attitudes towards advanced care planning and interventions for patients with ALS. So specifically, we looked at patient comfort level in talking about treatments, CPR, ventilator, feeding tubes, power of attorney, advanced directives. And you'll see patients are comfortable or very comfortable talking about these things. They want to be having these conversations. And so I think the onus is on us to start the conversation, gauge where they are, but most people are going to be very willing to engage in these talks. When it comes to who should be involved in these, we ask the same question: who are you comfortable sharing this with? And again, the primary care doctor, the neurologist specifically, they are very comfortable having that conversation. So physicians, they want us to be having these conversations. Bring in the spouse or the caregiver. It's very important for them to be having those conversations. I found it surprising that even over 50% of the patients were willing to talk about this with friends. So it was the lowest score on there, but still 60% of them were comfortable or very comfortable talking about it with friends. So this is something that patients are waiting for us to have that conversation and talk to them.
Can I just tagging on to that? This is a little bit of shameless self-promotion, but since it involves one of a neuropalliative patient, some of you know that I do a podcast with Jason Beckrow. It's called Palliative Matters, and we had the opportunity, really at the request of the patient and his wife, to interview them just about a year ago to talk about their experience of and the benefit that they were having with palliative care in the midst of their progressive neurologic disease. And it really was quite a compelling conversation, and one of those, not because of anything Jason and I did, but because of the patient and his wife and what they were able to contribute and talk about their experiences with the disease progression. I don't necessarily promote this all as I should, I don't know, but I would highly recommend that, to hear the story of a neuropalliative patient and what they were experiencing, and just the nature of what the disease was doing to them at the time as a family and as a couple, and behaviorally, and was really, to me, quite fascinating. And for them then to be able to link back and show the benefit of palliative in their quality of life and allowing them to make appropriate decisions and such. So it was our season 2, episode 8 was broadcast. It's a Trillium Institute. If you go onto our website, trilliuminstitute.org, and go to the Palliative Matters podcast tab, you can find it there. So.
I don't think you guys made it to the neurology symposium last year, but he was willing to come share his story with our neurology team as well. And that was just very powerful and moving to have him come and share his story there too. But so when we look at patients feeling informed about interventions such as CPR and decision-making, and whether or not they've come to a conclusion on CPR, decision-making, living wills, it turns out that the more informed they feel, the more likely they are to have made a decision. So these are looking at these 5 different treatment interventions. You can see just the comparison between the maroon is feeling informed and the light blue is patients who don't feel informed, and the rate of having made a decision. So it's quite a significant difference. We were able to find significance in 3 of these, but you can see even in ventilation and feeding tubes, there's a trend toward having a better idea and having made up their minds. So good to be able to provide that information for patients. I say this also with a caveat, having made up their minds or having come to a conclusion, those things can still change. So this is just a snapshot in time. People may waver back and forth depending on what their illness is. So just because they said, now I've made up my mind, it may still be good to circle back later on and say, hey, this is the path we're on. This is what we've chosen to do. Does this still make sense? And as disease progresses, we may say, no, that peg tube doesn't make sense now, or things of that nature. So take a look at this list. This is really a list of things that will trigger end of life in patients with neurologic conditions. So dysphagia itself can trigger end of life, recurrent infections, decline in that functional status, that first episode of aspiration pneumonia. So we're not waiting until that second, third, fourth admission to the hospital, but even that first episode tells you that we're reaching that stage where cyclic rehospitalization may become an issue. So let's talk about that now. Cognitive difficulties, weight loss, symptoms are becoming more complex or difficult to manage. And again, with Parkinson's, weight loss plus that less effective that Sinemet or the other movement medication shows that that disease is really taking hold. So with the last few minutes, I want to emphasize the role of caregivers in this. So this study looked at caregiver burden in patients with ALS, Alzheimer's, Parkinson's, ABI is acquired brain injury, and then MS. And on this caregiver burden inventory, 35 was the cutoff for a likely caregiver burnout. And you'll see that patients with ALS and acute brain injury really scored the highest and are above that burnout threshold. Alzheimer's and Parkinson's gets close. And then again, MS, change in treatments that are available, that caregiver burden is much less for that population. I use this is the ALS FRS score. I use this more as a reference for the next slide, but it's a functional rating scale that we use in the ALS clinic to determine that functional severity. So it's a 48-point scale. 48 is your functional independent doing very well. And then I think it goes down to basically the lower you go, the worse off your function is. So looking at that, now looking at caregiver burden, time spent in caregiving. If somebody has that ALS FRS scale of 30 or greater, they're still requiring 5 hours of daily care for that mild disease. So this may be somebody who's balancing a full-time job. They have to get up a couple hours early to help their loved one get up and get ready for the day. Coming home from work, they need to prepare meals, get that loved one ready for bed at night. But as the FRS scale drops, you're looking at 15 hours of daily care that's needed for patients, for toileting, for bathing, for dressing, for feeding. But you can see all the tasks below. It goes beyond that. Medications administration, supervision, housekeeping, transportation, coordinating doctor's visits, all of that kind of falls on the caregiver. You'll see it takes anywhere from 1 to 3 caregivers early on. And again, half those caregivers are still working full or part-time jobs. The way the system's set up in the United States, we need to maintain our health insurance. And how do you do that? You keep working. So there's a lot on these caregiver plates trying to balance the household and care for their loved ones. And when you do get carers, professional caregivers into the house, that can be a huge financial burden for patients. So taking that a step further, this study looked at patients with ALS and their caregivers, and they were surveyed and asked, what has your stress level been over the last 2 weeks? So you see the blue is a stress level of the ALS patients. They're kind of ranging in that low to medium range, where the caregivers are in that high to maximum range. So the caregivers are actually experiencing more stress than the patients are. A lot of that is for reasons we mentioned, but that financial impact, 35% report that's been devastating to the finances. And a lot of times caregivers put their own health to the wayside, and their own health can worsen because they're not making their own doctor's appointments, doing preventative medicine in treatments. So they're less likely to report positive response to interventions compared to the patients themselves. So and then with dementia specifically, if a patient has dementia with their ALS, caregivers are 3 times more likely to report that higher burden. So that dementia just adds fuel to the fire. There's an emotional burden to caregiving as well. Patients are unable to live their own lives. There's negative feelings towards the patient who can't do anything for themselves or is not the person they married or who they knew growing up. So there really needs to be a lot of support for the caregivers, and the support really needs to focus on planning. These are things that are not changeable, but how do we plan for them? Look at particular problems. What are those things that we can solve today or make a little bit better today? And then identify what is modifiable and what is not modifiable. What are those things that we just have to say, this is what it is, and we're going to have to just kind of factor that in. But no matter what we do, X is not going to change. Just identifying that can really help put things into perspective. So when we're looking at interventions and the burden of interventions, as we mentioned earlier, reevaluate the interventions. Are those things that are still helping patients? Are they appropriate to continue? Or is the care disproportionate to the benefit? Is having that PEG tube in truly providing that benefit? Or is it becoming more work for the caregiver to provide the feeding, to do the maintenance of the tube, those sort of things? We do need to consider that caregiver burden that an intervention places on the carer. Is there substantial benefit to the patient to justify the time invested by the caregiver? Oftentimes in the United States, we focus on autonomy of the patient, but when we look at the other principles in the ethical principles, there's that balance of justice. What is my choice? What does that impact have on those around me? Or what does that choice have on the community or the resources around me? So we do need to factor in autonomy, but it's worth having the conversation about who else is involved, who are the other stakeholders, and what does that mean for that overall global picture for everybody affected by the illness. So again, in summary, we talked about the inpatient outpatient approach. Approach varies by presentation. So we've got neuro-oncology, different from neurodegenerative, different from acute issues that can turn into static issues. We talked some about that trajectory and that uncertainty in the acute setting and then caregiver burden. So with that, here's another shameless plug. If you guys are not busy, September 20 to 22, the International Neuropalliative Care Society is meeting here in Grand Rapids. So that Friday is dealing more with workshops, but Saturday, Sunday is educational sessions. So there's more information at the website inpcs.org. But go ahead, take a look at that and get registered if you want to learn more about what we're doing.
And I would just tag on to that. I don't know if it's one of the reasons it's in Grand Rapids, but we are extraordinarily honored and privileged to have Dr. Phillips do this as one of the kind of pioneers of the international neuropalliative movement. He's been involved in this for probably close to a decade now, helping with the formation of the national, international focus, and has had leadership roles in that. And so we're just, it's really kind of neat to see a specialty evolve around one of our own. So well done.
Oh, thank you.
Well done. Just as a quick housekeeping, we had some little tech issues at the beginning. If you happen to put your credentials in for CME before the lecture started, please re-enter them because we were not capturing them until Joel started talking. With that, we'll just open it up for questions or comments for Joel.
So when you mentioned the PEG tube affecting the prolonging life, because ALS has a cachexia involved, does it actually prolong life in that condition specifically, or is
in ALS?
Yeah.
Yes.
Okay,
Yeah.
even with that state of.
Yeah, even in more of the advanced stages, it may not be as helpful, but we've got patients who will put it in. We actually emphasize putting it in early before respiratory muscles of respiration drop too far because it gets riskier to put a peg tube in later on. So oftentimes we're talking about placement before it's needed. And then patients can do quite well because the gut isn't affected to the same extent. And it just becomes that means of getting food into the stomach, and the body can still process it and do quite well.
And then I guess kind of a related question: when you're doing those conversations about discontinuation, kind of what are the main points you're focusing on like that discontinuation point?
Yeah, yeah. A lot of it, well, like I said, I'd like to at least start the conversation about a peg with the idea that we can stop it, so that that's on the table from the beginning. So that way, when we do come back to talk about it later on, it's not a big surprise. It's like, oh yeah, that's right. Dr. Phillips had mentioned this early on. Um, I'd say that a lot of the conversations about discontinuation are probably happening more on the hospice side of things by the time they get into the hospice setting. Usually when I'm sending patients over to hospice or we're getting enrolled, they're still doing well on it. They're tolerating feeds well, and it's not something that I specifically address as much as I should. But for those who do have ALS patients in the hospice realm, feel free to chime in. But I would imagine that as we're getting into more of the very end stages where we're seeing more more lethargy, patients are sleepier, more obtunded, we're probably having the conversation at that point to say, you know, the feeds are probably not doing what they had been doing weeks or months ago.
Sometimes it's like a tolerance of that, you know, that motility continuing to decrease, and they'll feel bloated even with small amounts. They're having that kind of sensation of regurgitation, and it's that risk of aspiration that you'd mentioned in a few slides as well. And on the flip side, with our stroke patients, you know, we expect to see the most significant amount of motor recovery within that first 3 to 6 months. So sometimes that PEG tube is that bridge for nutritional delivery while they're recovering their swallow, or using swallow strategies to make swallow safer with speech therapy, you know, whether that's the swallow strategies or modified diet, and then they can improve and diet advances and we don't need the pig tube anymore because they're meeting their calorie goals orally instead of needing that nutritional supplement.
But I would say it's also a good thing to discuss because at some point patients may find that they're in a situation where they don't find it an acceptable quality of life. And that peg tube is providing calories, nutrition, kind of is a life-sustaining treatment. So it's fair to have that conversation and say, if this is no longer providing that benefit in the sense of, I don't want to be in the state that I'm in. I want to focus more on allowing the disease to take its natural course at this point. That's another point of conversation where we can say we can stop the feeding tubes. It goes back to that or same sort of principle with tracheostomy or invasive ventilation, where we say, you know, we tried the ventilator, the disease is progressing, it's no longer going to be effective for you. We can remove the ventilator in the same way we can remove the feeding tube or stop feeds.
Hey, Joe, I was going to ask you a question, please. You were mentioning, about the caregiver burnout. I'm just wondering, like, if your program or how are y'all addressing that?
A lot of it,
I know it's not that, but
so a lot of it is support groups. So for our neuro-onc patients, we have Gilda's Club in town, which does a great job of providing care for patients and for their loved ones and caregivers. For ALS, we do have the Susan Mast Foundation, which is that grassroots organization that developed probably more than a decade ago at this point. They've got a lot of support groups for caregivers, for patients, but they do a few other things. They provide frozen meals for families to kind of take some of that burden off, but also provide some respite care. So if patients can coordinate care, get paid caregivers into the house, Susan Mast will then reimburse for that care. So there's some financial assistance for getting extra respite into the house. So there's a few things that we're able to do locally to help.
And I think that those sorts of things really, in my experience, also are kind of most important. Number one, they're not alone, and the support groups really kind of reinforce that. And two, we need a break now because it's so intense and never ending. So those are two great resources.
This doesn't tie it into ALS or that, but one of the things that we did down in our organization is open a kind of an elderly hospice daycare. Y'all might have something like that. I'd never heard of one where we actually, they can go to work, the family, and then their loved one who's on hospice can go to the daycare and interact with people. And it's not like you're being stuck in a nursing home. They're doing activities and they're engaging with these people. And you don't necessarily have to do it yourself. But how that gets paid, that's tricky, right?
Yeah, that's a relatively novel model that is the cost of that is borne typically through the hospice by philanthropy or perhaps a grant, but it's an unusual model, and it's really predicated on, and it's kind of deviating from the topic here, but the challenge there is that because hospice length of stays are still relatively short, the majority of hospice patients, even though the mean length of stay right is now pushing 40 days, in general, half of your patients are dead within 2 weeks of admitting to hospice, which means that their physical condition is not such that they can necessarily be transported or be functional within, an alternative setting. They're pretty much bed confined, home confined. But for those subsets of patients who have specific needs but are otherwise ambulatory and functional, those types of settings are really kind of intriguing and do a really interesting job. So.
Thank you, Joe.
Thank you, Joel. Yeah.